Hi, everyone. I hope you're all well. Um, Today, unfortunately, we've got a bit of a serious case that needs to be discussed. It's quite harrowing, actually, and something that actually came across my desk um, a little while ago. Technically, I've put it down as the October Morbidity and Mortality Review, even though this patient was actually seen a bit earlier in the year. It just came back to my attention because I had to fill in the forms for the case that's going to go on in uh, in the courts soon, hopefully. I don't know if there's been a resolution to the case, but it was quite a harrowing case. But in any case, it gives us an opportunity to learn about burns, which is not always something that we have a chance to. Luckily, it's not something we often get a chance to see in its entirety. And this was quite a severe case, unfortunately. So what we're going to do is we're just going to cover the morbidity and mortality side of it. I was hoping to do it live in the department, but they were quite busy today. And with it being December, there's a lot of trauma coming through. So she and the ladies, they are, the doctors, they're really pushing hard, and I give them a lot of credit. And it's not for me to come and take out 45 minutes of their time. There's too much going on. So I hope it will be okay if you guys just will just stick with me for a little while. And yeah, let's see if we can go through it. All right. So, like I say, so this is a case that came across my desk. I haven't identified the patient. It's quite a harrowing case. It even came in the local newspapers. And my understanding is that a suspect has been placed in custody and that hopefully a case will be taking place soon. May have to testify in it as well. But this was a young 14-year-old girl uh, who on her way back from school was abducted, and we suspect that she was sexually assaulted. However, after the assault, the suspect later set her alight, and she was brought in with the full thickness burns of the entire body and inhalation burns as well. And she was still alive when she came into the emergency department. Uh, Thankfully, she didn't survive very long. And thankfully, as we learn later, with full thickness burns, at least the pain is not as severe. But this is one that really gets to you and lets you understand that in South Africa, we sometimes see things that are quite horrifying, and the level of violence that we sometimes are exposed to, not things that many people in the world can understand. I mean, this case didn't even make national, provincial news. It's just been a local story. So in any case, yeah, so she was abducted. We suspect she was sexually assaulted, but all of the evidence had been burned away. She was brought into the emergency department with severe burns and laboring respiration. It was decided immediately that the prognosis was extremely poor. The one thing that I didn't put in here, I think there was a laryngeal mask airway that was inserted after sedation and analgesia. Sorry, let me just add that on here because she was sedated. Sorry, let me just add that on while we're there. Yeah, because the amount of damage that had taken place to the oropharynx made it almost impossible to actually insert an ET tube. And it was, like I say, there was not much chance of anything else really. There was practically no chance of a good outcome in this patient, and she remained unconscious and demised after approximately 1 hour. There was a bit of a consult with the surgical department to just confirm that she was not for active resuscitation, and we'll get into why in a second. The clinical discussion, basically, if we look at burns, we'll get into this in a bit more detail, but the way that you classify burns are superficial burns, which only affect the outer layer of the skin, causing redness and pain. You get superficial and deep partial thickness burns, which extend into the upper layer of the dermis, causing blisters and more intense pain. Deep partial thickness burns, which reach deeper into the dermis. They often damage nerve endings, sweat glands, hair follicles. You generally don't get too much of pain with these. So it's a little bit better for the patient. And of course, full thickness burns, which penetrate all skin layers and everything, anything below, right down to the level of bone, would be then considered as full thickness burns. And it's destroying the area completely. And like I say, it possibly affects the underlying tissue as well. So this is the current way of classifying burns. We used to have first, second, and third degree burns. And if you use that, I don't think too many people would have a problem with it. We still understand what it means. It's just that second degree burns have basically been divided up a little bit more, because you tend to get there is a bit of an overlap. There is a bit of a difference, and just saying second degree burns doesn't really differentiate between these two. And the most important differentiating factor for yourself, if you need to remember, is the amount of pain. So deep partial thickness burns, the pain is often less than with superficial partial thickness burns, which are often the most painful. So you get, of course, inhalation burns as well, where patients will often have signs of respiratory distress, soot in the sputum, singed nasal hairs and hoarseness, blackness of the oropharynx, soot in the oropharynx, and any sort of swelling around the face and of the head and of the oropharynx should immediately alert you to the fact that these patients have inhalation burns. And inhalation burns add 10% to your overall tally of your percentage as well. So your complications, of course, are airway obstruction and respiratory failure, carbon monoxide poisoning. But truth be told, if you have signs of inhalation burns, the first thing that you need to do is intubate this patient. You need to make sure that you have a viable airway for the patient. And if the airway is already compromised, you may well have to go to a surgical airway as well. So in this particular patient, the extent of burns and the inhalation injuries, prognosis was extremely poor for a few reasons. She would have already gone into renal failure. She would have already gone into respiratory failure. It would be impossible to perform any sort of grafting of natural skin. You would have to look at artificial skin replacement, which is not available in our public health system. You would, of course, have an extreme metabolic load on this patient. Should be losing protein through that exposed areas. Well, I mean, at a ridiculous rate. And essentially, she would just go into, well, she did go into multi-organ failure within a very short time. So in a case like this, and this is the second one that I've had, about 5 years ago, we also had a woman who had, unfortunately, had the bad idea of double-crossing a local loan shark. And she was also brought in a similar situation. And it's probably the most amazing thing I've ever seen, because you have this woman who's completely burned from head to toe with inhalation burns, just sitting and looking at us. She's literally just sitting and looking at us, because she's developed complete anesthesia, because there's no nerve endings, there's nothing to carry the signals of pain. And I can tell you that particular one, IV access was quite an issue. We ended up putting an intraosseous line for the patient. Actually, we ended up putting in two, just so that we could sedate her, and at least, let her be comfortable, if nothing else. And I remember our late head of surgery, Dr. Shilen Chetty, who's late now himself, came in, just looked at her and just said, make her comfortable. And I still remember the look of shock on his face, because he also hadn't seen one since his registrar days. And, it's quite a harrowing experience to see patients with such severe burns, So the main thing is that you focus on pain management, comfort for the patient, and you would expect severe electrolyte imbalances, because there's such severe cellular destruction. Your patient just becomes hyperkalemic, hypercalcemic. They're losing sodium through every orifice of their body, through every patch of their body. They're just losing everything. And like, say, renal and cardiorespiratory dysfunction. So the question may be asked, okay, up to what stage do we say that there's still a prognosis? I'm not sure if the teaching has changed on this, but when I was doing research on this particular topic, up to 80% burns, even full thickness burns, there's still a possibility of recovery, although the prognosis is extremely poor. Above 80%, there's almost no hope. Above 90%, it does drop to basically zero. So below 80%, and it depends on the situation that you're working in. So if you're working in a well-resourced, well-funded unit with a specialized burn unit, plastic surgeons, availability of artificial skin replacements, skin, they've got such wonderful things. I was reading in Brazil where they use the skin of that particular fish. I think it's the tilapia fish, even though that's used particularly there, but skin replacements, artificial skins, spray-ons, 3D printed skins. If you have all of those available, your prognosis immediately goes up. If you have the ability to ventilate these patients for long periods of times, if you have immediate access to dietary supplementation, you have immediate access to all of these things that need to be done, of course, your prognosis definitely goes up. And within the private sector in South Africa, a lot of these patients do well. There's been some wonderful documentaries on patients who've been quite severely burnt and have recovered. In our public sector, unfortunately, we don't have access to a lot of those things, even though there are specialized burns units available within our province of KwaZulu-Natal, for example. But the bar for entry is quite high. The prognosis has to be reasonable. So 80% and below, you're still looking at a possibility. And once you go above 15% for a child and 20% for an adult, you are looking at admission. Once you go above 40%, you're looking at a severe burn. And we're talking about total body surface area for an adult, and I think it's 25 to 30% for a child. I just have to make 100% sure on that. Okay, so in this case, the fluid replacement challenges due to the extent of the burns were quite bad. I mean, practically impossible, which I'll show you guys in a little while. So what were the lessons that we can learn from this? It's important to have rapid assessment and intervention. And as I was explaining, there are challenges in managing extensive burns. And palliative care is providing comfort in cases with poor prognosis and debriefing the team. So, it's quite a traumatic event for anybody to go through, and we as doctors, nurses, allied health workers, we're human as well. And there's only so much horror that we can take as well. And it's quite important that if you are working in such a unit, that the debrief takes place. Now, in our unit, unfortunately, debrief did not take place. That's on my head. We probably need to do this with the team and do it soon, but I can understand the impact that it had on them. These are just recommendations within the department. We do have protocols that run into this. This is just a summarized protocol that I've got, and I'll, you're more than welcome to have a look at our protocols on the website. It actually covers all of this as well. This is just for the purposes of documentation, because we do have to submit all of these morbidity and modalities to our management team here, so they do need that as well. So I just wanted to get into some other things. I just wanted to share this with you guys. Let me try and get it up here. All right, so we're just going to have a bit of a deeper look at burns. So when we're talking about superficial burns, we are talking about redness. So the affected skin appears just red. You may have mild to moderate pain, which is often the most notable symptom. You may have slight swelling, there's dryness, there's no blisters. That's the important thing. So superficial burns do not usually form any sort of blister. So once you see blisters, you're going to superficial partial thickness burns. The skin remains intact without any breaks or tears. It's extremely sensitive, so it's hyperesthetic, and especially to touch and temperature changes. All right. Healing time is generally within 3 to 6 days without scarring, and peeling, it may peel. And like I said, they typically do not leave scars. So superficial burns are quite a common occurrence in any emergency department. And very often it's more reassurance and analgesia. For younger kids, we do give stronger analgesia, especially to the parents going home. If you are working in private and you have access to much stronger analgesia, you can. I often put them on non-steroidals as well, NSAIDs, in the public system, because it's one of the it's just an adjunct to your normal paracetamols, and it helps with the swelling and things like that that the patient is experiencing. Now, all of these have been made available on our website as well, so you don't have to worry about screenshotting these. I'll show you all of these in a little while. So here we have superficial partial thickness burn. Now, I must be honest, I'm no artist. This is from Midjourney. This was the best that I could get, so please don't think that I'm drawing this or finding these anyway. It's just to give you an example of what you would see. So redness, the affected areas are red and inflamed. The pain, it's more intense pain. In fact, it's the most intense pain from all of the burn categories that you get. It can sometimes be very mild if it hasn't gone that far in, if it's just affecting the nerve endings to a small amount, but I have had patients screaming in pain. And sometimes they do even require admission for pain management. So the swelling tends to be more pronounced. You will get formation of blisters with clear fluid. Now, there is a thinking that you should remove the fluid. My personal feeling is that if something is covered and not exposed to the outside, don't expose it, because you're just going to expose you're just going to have the potential for pathogen entry. I have seen some surgeons on occasion remove blisters and apply dressings and things like that. I go back to my teachers. When I was doing surgery at one point in my life, when I still thought I could be a surgeon, and they, having worked at that level, they were quite keen on keeping blisters intact, not removing the fluid. In fact, I remember one of the surgeons who I worked with used to actually do skin grafts for a lot of these patients and then apply sponge on top of it to help. So there were some wonderful things that you learn when you actually work with burn specialists and plastic surgeons. And if any of you do get a chance, I would suggest doing a rotation through plastics and burns management. It really is quite amazing. So you have a wet and weeping surface as compared to the dry. It's also extremely sensitive, so it doesn't affect everything. You just have the epidermis, possibly part of the dermis sometimes, but not always. There is a potential for scarring and pigment changes, which we often see in our patients later on, and generally heals within 2 to 3 weeks. The risk of infection is higher. So that's why I personally don't recommend popping of blisters, removing of intact skin, and things like that. Normally, if you've got a blister, let's say that's spontaneously ruptured, I would normally apply an antiseptic dressing, but without removing the skin that is already there. We go to deep partial thickness burns. Okay, that looked less horrifying when I initially found it on Midjourney. So my apologies. That actually looks quite terrifying. But so you've got this burn area that may show a mix of colors, red, white, possibly charred patches, depending on how deep it goes. So what happens is, and this you'd notice especially with hot water burns, which are often the culprit in deep partial thickness burns, at the area where the heat is the most intense. And this can happen with any sort of burn, but that's generally where most of the blanching and whiteness takes place. And then as you get further away, that's when you get more to the red and things like that. So that's how you can know where the burn originated from. So especially in high heat burns, so let's say, for example, an acetylene torch burn, you may get charring at the middle and then blanching on the outside. So you may get like a charred area and then blanching and then redness as you go further and further away from the from the source of the heat. These can be extremely severe. I remember a friend of mine's actually who, a lovely guy who used to actually, he was a plumber in our area, and he had actually set up the plumbing in his own home, and there was some thing that he did incorrect with his geyser, and he didn't connect the cold water correctly. And first time he used it, he didn't realize, and he opened it up, and it was just hot water that came out at about, well, they normally set to about 67 degrees Celsius. And he got so severely burned. I remember he spent about 2 months in our local hospital. And it was just amazing, because as hard as he tried to get out, the shock of it just kept him there. And he wasn't there for more than about a minute, but the amount of damage that was done was quite incredible. And the younger the person, the quicker the damage takes place. So they reckon a newborn it takes a single second of exposure to, let's say, 67 degrees Celsius, which is the typical level for our hot water heaters, geysers in South Africa. But that 1 second of exposure is enough to cause a deep partial thickness to full thickness burn, and then up to a minute for an adult, So it really happens quite quickly. They do have reduced pain sensation over certain areas. And as you go further away from the main point, the pain can become quite severe. There's often severe swelling, large blisters. They may rupture. You may see wet layers underneath. There's less blanching to pressure, so the skin does not turn white when pressure is applied, indicating reduced blood flow. So they can have a mixture of dry and moist surfaces. It can be dry if it's deeper structures, moist if it's closer to the surface, and very moist if there's adipose tissue involved. Adipose really does leak a lot. There's a high potential for scarring. Most of these patients will require skin grafting. And for those of you who haven't had a chance to sit in on a skin graft, it's an essential skill for any doctor. Please, even if you're not somebody who's interested in surgery, while you're doing your junior rotations, go and learn how to do a skin graft. It's an amazing procedure to witness, and management of burns is something that we all need to know. Slow healing is an understatement. It really can take months for this to heal. Risk of infection is extremely high. And a lot of these patients, especially with extensive burns, now once we're getting to the deeper layers, actually more of them succumb to the infections as compared to the complications of the burn itself, because they're at such high risk. Now, I mean, there's so many complications that occur with burns, from gastric to renal, cardiorespiratory, electrolytes. There's so much that goes off. But really, septicemia and sepsis is one of the things that they really worry about. This is why when you go into a burns unit, the infection control is so strict, And if you've worked in a burns unit for any period of time, you'll understand why. I had the fortune or misfortune of running a burns unit. Well, when I say running, I mean, of course, with a consultant, but I was the main medical officer there for about 6 months. And I can tell you that it was horrifying to see what some of the patients went through in terms of pain, in terms of complications, the amount of work that they actually need. It wasn't a big unit. There was only 6 beds, but it would often take me the entire day plus more to make sure that everything was sorted out in this patient. And it's one of the most exhausting times of my life. And then, it's partial thickness of the skin. So it involves the deeper dermis, but not the full thickness of the skin. And of course, it's very rare to actually just see burns in one particular. So in other words, we often get a mixture. You may get areas that are partial, superficial, then deep superficial, and full thickness. So always keep that in mind as well. And then full thickness burns, where the entire skin has been burnt away. So the skin appears white, brown, charred, or even blackened completely. There's lack of pain because there's complete destruction of the nerve endings, leathery texture, which may feel dry and stiff. There's no blistering and eschar formation. So these are hard, thick, dry scabs that form over the burn area. Now, eschars form their own problem, especially around and the neck, the chest, the abdomen, and of course the legs and the arms. The problem is that they cause a very severe compressive effect. So the main thing that they cause around the chest, for example, is inability to have sufficiently adequate respiration. Around the neck, again, you have vascular compression, the same thing with the arms and the legs. So if you have eschar formation, it's one of those things that you would consult a senior if you haven't done it before. But I've done a few escherotomies in the emergency department, where basically there are no nerve endings. There is no pain for the patient. You basically just slice open those areas and allow them to swell. So basically, it's kind of like cracking a ring. You basically break a ring so that you've got 2 separate halves, and the patient can then breathe, blood can flow. It does increase the possibility of infection, but this is not something you should be handling as a junior doctor. It's something really that a senior should be doing. It's one of the most harrowing procedures to do in an emergency department. And if it has to be done, it has to be done. And patients often show immediate improvement. You've decreased the chances of compartment syndrome, often in the limbs. It can be on something as small as a toe sometimes, but it can really help the patient later on. So SCHAs in themselves, and burns is a huge topic. We can spend weeks talking about burns. I'm just trying to get through the basics. Inelastic skin, so it does not stretch, is not pliable. Insensate, as we had mentioned, there's complete loss of hair. Thrombosed vessels are quite easily seen most of the time, and this often occurs even with a deep partial thickness, and the potential for complications is extremely high. Fluid loss, systemic complications, systemic infections, it really does get quite bad. So I just wanted to take you guys just to our ED assistant, just to show what I've tried to put on there for burns. So I've put burns under resuscitation because it is quite important. So there's an entire section here that deals just with burns. Again, first degree, second degree, and I've tried to keep it as that because a lot of people still use that. Some of the additional considerations that we have, electrical burns, and of course the emergency department management of burns. Now, it gives you a basic area, a basic understanding of what needs to be done. These, of course, are all clickable and available on your phones as well. So if you need to know exactly, especially with the youngsters, because the percentage of the area actually changes, so for example, the head comprises 9.5% in birth to 1 year, but in an adult, it's only 4.5. Now, there is an app that's available in South Africa called the Vula app, which you can use. And as far as I understand, it's got artificial intelligence that helps you map out and actually work out your percentages. There are some of these things available online. And even though I do a bit of programming, I'm not at that level at all. It took me a day to actually be able to make this get big and small. So it's something I'll be able to put up for you guys. But it just gives you something just to help you as well. We all know the rule of nines for burns, and it's something that's applicable, especially in adults. And here again, we see I've put one for children as well, just to give you a chance. And these are the exceptions for pediatric patients, and that's what you need to know as well. So it just gives you an idea of the differences between adults and children. And the reason for that, and the reason for knowing the percentage, is not for fun. It's because you need to be able to work out, number one, your fluid replacement. You need to be able to know if your output is correct. You need to be able to supplement your electrolytes. You need to have nutritional supplement. There's so many things that you need to be able to work out, especially if you are in the burns unit. Here we have just those same slides. So I've just included it here so that if somebody needs to go through it. What I've included as well over here is the advanced life support guidelines as well. Let me try and bring that up for you guys so that you can see. So this is the advanced burns life support course. Now it's a bit outdated, 2018. It's not possible to get the new one, but it goes through everything that you need to know about burns, especially from an emergency point of view. And when you are working in the department, as you can see, it's a huge document. It's there we go. It's 91 pages long, but it's extremely valuable, and really something that I would suggest that you take and put on your phone and keep it there. Or if worse comes to worse, at least know that it's available here for you as well. I've put on a burns fluid calculator. Now, just to explain to you, for our patient that we had, she was approximately 67 kilograms, and she had 110% burn. So if we had to calculate the fluid replacement, she would need 1,842 mils per hour for the first 8 hours and 921.25 mils per hour for the next 16 hours. And as you can see, that's number one, it's not viable to give somebody that amount of fluid, of whether it's hypotonic, isotonic. You're just going to cause more harm than good. But it's quite a good calculator if you just need a basic burns calculator. Let's say you've got somebody who's 82 kilograms, for example. I remember being 82 kilograms. I think I was about 7. I've grown up since then. And let's say they've got 36% burns. That's what you've worked out. So this will actually give it to you. So they need 738 mils per hour for the first 8 hours, and for the next 16, 316. This is quite a significant burn. Let's take a slightly smaller child. Let's say somebody who's got well, let's say 32 kilos, and let's say they've got a 44% burn, which is quite significant. They need 352 mils per hour, and for the next 16, for the first 8 hours, and thereafter 176 milliliters per hour. Now, of course, if you are somebody who's working in an area where they use weight in pounds or stones or whatever it is, you'd have to convert to kilograms in order to be able to use this calculator. But I hope that this calculator is something that will come in handy for you guys and that you will be able to use it. Like I say, a very harrowing case. And I'm not looking forward to going and testifying because it's hard to keep your emotions in check for something like this. And it just shows you what some people in the world have to deal with, and makes you thankful that maybe you're not in that position. Thoughts and prayers should go out to this child's family. I'm not going to give you all the name, but just remember her in your thoughts and in your prayers. Um, Sorry to add this little bit on at the end. I realized after I completed that I completely missed out two slides that I also wanted to show you guys. So I'm just adding it on here at the end. We just look here at inhalation burns, which is something that I didn't cover. So we're just going to look at the signs of inhalation burns. So facial burns, generally singeing around the nostrils, loss of hair around the nostrils, but any sort of burns around the mouth and the nose should alert you to the fact that there may well be an inhalation burn. And singed nasal or facial hair, if it's somebody like me with a beard and you can see, it looks like it's singed, there's a high possibility. Soot in the sputum, so black dark particles in the saliva or the mucus, highly likely that there is an inhalation burn. Once you have hoarseness or change in the voice, that shows you swelling is now occurring within the larynx over there and could well be due to a laryngeal edema or direct thermal injury as well. Any sort of stridor, wheezing, labored breathing, immediately, listen, this airway is in trouble and you need to go into it. Persistent coughing, which may be productive or dry, depending on which part is affected, and is also an indication of possibility of inhalation burns. Throat pain, soreness or pain in the throat, along with burns on the interior, should alert you to that fact. Carbonaceous sputum, so presence of carbon particles in coughed up material, shows you that it's gone quite far in. And hypoxia, simply because of the thermal damage to the pulmonary cells, there's inefficient exchange or VQ mismatch that occurs. And of course, that would lead to an altered mental status and confusion or disorientation due to hypoxia. So you may not see something as extreme as this, which Midjourney put up for me, but it gives you a good indication of what could be there. So and especially with the facial edema, it is very possible. So we had a gentleman who worked in the security services. I think this was in my first year at Morbidity, and they had actually followed up on a bomb threat. And while he was despite being in bomb protective gear for the unit that he was working in, and it was quite close to the hospital here, the device did explode, and he came in with quite severe facial swelling. And I remember it was quite an argument. I had just started at that time, and it was an argument between me and the surgeon because I really felt that the patient needed intubation, and they were like, "Nah, it's not necessary. It's only external," and things like that. And they took the patient, and later on they had to put in a surgical airway for him. And I always remember, because of shame, the poor guy never had to go through that. But anyway, so and these are the indications for intubation. So any sort of airway compromise, so swelling, burns of the throat, the patient is in respiratory distress, the first thing that you do is you just get them ready to intubate. There's a decreased level of consciousness with burns around the face. This patient won't be able to protect their airway, and it is going to cause problems. If there's severe facial burns accompanied, of course, by signs of inhalation, but with severe facial burns, one of the other things that happens is that very often the swelling may spread along the subglossal area, and you may also have problems later on, with the patient then obstructing their own airway. Burns to the neck and chest, as I mentioned before, in SCHAR development, that could well happen. Carbon monoxide poisoning also occurs generally with smoke inhalation rather than with burns, but it's something where you just provide high flow oxygen, and it normally helps the patients, but they do have to be in hospital. And of course, hypoxia. And if you anticipate that the swelling is going to get worse, as I mentioned, then those are the things that you can. So sorry for this little 2-minute thing. It was only after I'd finished off that I realized. So thank you so much, guys, and keep well. Bye. In your prayers for a young girl to have her life ended in such a traumatic way. It just breaks my heart. Just breaks my heart. And like I say, they do have somebody in custody. Whether he is or not is not up to me. I don't know. I haven't been in contact with the detective for a little while. I think I filled in the forms now about 3 weeks ago, and we haven't had any contact with him, but they were quite certain that this was the gentleman who did it. I think there was some evidence linking him to the area at the time, and there's a history of violent attacks and previous arrests and things like that. So if he is the culprit, I hope they put him away for a long time. Sorry to have a bit of a downer this time, but it really was a harrowing case and not something we can really laugh about all that much. But in any case, I hope the burns calculator will help you guys, as well as some of the other resources that I've made available. And hopefully we'll have another teaching session soon. Keep well, everybody. Bye.